paper presentation for PC700, Introduction to Scholarly Writing. I conducted research on how to reduce perineal trauma during vaginal childbirth. This is for my course PC700, Introduction to Scholarly Writing at Frontier Nursing University. Perineal trauma is common during vaginal childbirth. The risk of perineal injury is particularly high for primiparous women, Asian women, and women with a family history of severe perineal trauma. Perineal trauma, also known as vaginal lacerations or tears, are ranked in order of severity, 1st degree through 4th degree. Mayo Clinic has a great slideshow differentiating the different degrees of trauma. Here is a drawing of an intact vagina and perineum. The next drawing shows a 1st degree vaginal laceration involving only the skin of the vagina and perineum. Here, the picture shows a 2nd degree laceration, which also involves the perineal muscles. This drawing depicts a 3rd degree laceration with perineal muscle involvement and anal sphincter involvement. This last picture shows a severe 4th degree injury in which the lining of the rectum is damaged as well. Repair of 1st degree and 2nd degree lacerations are typically performed at the bedside with suturing. However, 3rd and 4th degree perineal lacerations may require surgical repair. An episiotomy is the intentional incision of the perineal skin during birth by the attending provider to enlarge the vaginal opening. Episiotomies are considered perineal trauma as they do require suturing. Perineal trauma can lead to significant morbidity for childbearing women. These injuries can lead to short-term and long-term complications, including painful intercourse, fecal and flatus incontinence. Psychological and social problems may also result from these difficulties. Damage to the perineum also increases the risk of infection in the postpartum period and has the potential to lead to genital tract sepsis, hospitalization, and even death. These morbidities can have an impact upon a woman's ability to cope in the postpartum period and care for her new baby at this pivotal time in her life. Moving around during labor and maintaining upright positions are beneficial in aiding the descent of the baby. During the 2nd stage of labor, the pushing stage, positioning can have an impact upon the degree of perineal trauma. The supine position puts pressure on the perineum from the bed below and from the baby on top. Women should avoid this position for long periods of time in labor, as it is associated with higher rates of perineal trauma. Sitting, squatting, and using a birth stool have the highest incidence and degree of perineal injury, especially in primiparous women. The upright position and length of time spent on the stool may lead to perineal edema, contributing to laceration. Women who give birth on all fours or hands and knees position have the highest likelihood of having an intact perineum, followed closely by a kneeling position. These positions also offer the gravitational benefits of an upright position. If a woman receives an epidural, she may not be able to ambulate to upright positions. In these cases, a side-lying or lateral position is preferred over a supine position to protect the perineum. Research has been conducted investigating a hands-on versus a hands-off approach during the second stage of labor. When practicing the hands-on approach, the provider puts pressure on the baby's head and supports the perineum. During the hands-off approach, the attendant does not touch the mother or the baby during the birth. There is not a significant advantage for either approach with regard to perineal trauma. Some of the detrimental practices leading to perineal trauma include episiotomies. Routine use of episiotomy can lead to more severe perineal trauma, increased need for sutures, and more complications. Episiotomies should be reserved for instances where there are indications of fetal distress or suspected fetal compromise. Spontaneous vaginal deliveries are preferred over instrumental deliveries. Forceps-assisted births are associated with a high degree of perineal trauma. If an assisted device is necessary to expedite birth, vacuum extraction is preferred to reduce the chance of severe perineal injury. There is no evidence to suggest that the practice of digitally stretching the vagina or perineum when the woman is pushing reduces perineal trauma. This procedure may be distressing and uncomfortable for women and should be avoided. There are some perineal cares that can be performed to reduce the risk of trauma to the perineum. Performing perineal massage in the last weeks of pregnancy helps reduce the chance of severe perineal lacerations in primiparous women. This massage can be done by the woman or her partner at home regularly to help maintain an intact perineum. Although there does not appear to be a significant advantage for multiparous women, there is no harm. Warm compresses placed on the perineum during the second stage of labor can help reduce the chance of severe perineal trauma. Laboring in water can be soothing to women, and it seems to help soften the perineal tissue and facilitate stretching. However, research on perineal trauma during water birth has shown conflicting results. Further research is necessary to determine whether parity and length of time spent in water during water birth affects perineal integrity. Additional research is also needed to determine whether the amount of time spent on a birth stool has implications on perineal trauma. High-quality research is difficult to obtain because randomized controlled trials are often not ethical. Women should not be randomized into strict intervention and control groups. They must be given choices during birth and allowed to change their minds at any time. Episiotomies should only be performed when necessary if the baby is at risk. Vacuum extraction is preferred over forceps when an expedited birth is needed. It is good practice to review with women their options at prenatal appointments. The benefits and risks of certain positions can be discussed so that women can make choices based on the best evidence. Perineal care should be discussed as well, including perineal massage, hydrotherapy, and warm compresses. Making a woman do anything during labor can be considered an intervention. It is important to allow women to follow their instincts in labor and get into positions that are most comfortable for them. Often they will find positions most advantageous for them on their own.